Hey, Kim, can you enable screen sharing, please?
Yes. If I get my
Well, I'm
mouse
Matt
on.
Sabatsky. I am the Chief Transformation Officer at MedStar. We are the public utility model EMS system in Fort Worth, Texas. 190,000 EMS calls a year, fleet of 75 ambulances, peak deployment of 55 to 56 trucks per day into the system. We've been doing a bit of a Full integrated healthcare program since 2009. That program is fully paid for. In fact, it has a higher retained earnings than our ambulance operation. So, in our mobile integrated healthcare program, we see approximately 50 to 60 patients per day in that program and are getting paid to see every single one of them. So, program works pretty well. So, that's the brief background there. Let me see. Kim and Tim, are you guys able to see the screen on that side?
Yes.
Okay. So to kick off this summit, and I think this is a great topic. So Kim, good job putting the agenda together. Looking at EMS system design, we've been doing EMS essentially the same way forever. And the model for EMS is you call, we haul. That's all. Costs of readiness, what does the community want, et cetera, et cetera. But things have changed a lot, certainly over the last 50 years. And I would argue things have changed a lot, probably more in the last 3 years than they have in the whole 43 years that I have been involved in EMS. So for the next hour or so, really, I'm going to try and keep it to 45 minutes so we can do some Q&A. Here's what we're going to do. We're going to maybe do some myth busting about what people may think about EMS and show some data and some studies that what we believe may not be true. Do not shoot the messenger. I'm sort of glad that I'm not there with you guys because the darts and the spitballs might come out pretty strong. We're going to learn about what a lot of systems are doing to transition and transform their delivery model into ones that might be more sustainable and, quite frankly, based more on clinical evidence than they have been in the past. Going to learn how, if you want to do this in your system, how do you do some good testing? How do you propose it in a way that's going to pass muster for your local community? So here's what the catalyst for change has been. I think everybody in the room would probably agree that EMS response volumes have increased. We all suffered through a pretty dramatic call volume decrease in the beginning of the pandemic because everybody was afraid to go to the hospital because that's where COVID was. But response volumes have certainly recovered and gotten higher. What we've seen in our system is that the vast majority of the increases in calls that we're seeing are the increase in the low acuity calls, not the increases in the rollovers and the stabbings and the shootings and the heart attacks. In fact, our STEMI volume is really concerning to us. We're working jointly with our hospitals because our pre-hospital STEMI alert volume has dropped almost 50% over the course of the last 3 years. And we're trying to see, is that because more people are walking in? Are they dying at home? And has our cardiac arrest volume gone up? But it's the lower acuity calls that are increasing. Obviously, we have a staffing crisis. Most people know that. We're going to talk more about that, I think, in the second session that I'm doing later on this morning. But that's causing a lot of response challenges to that rising response volume, a lot of our response challenges. Cost drivers. And, costs are skyrocketing. Payments for EMS have not really fundamentally changed since 1950. I'm sorry, that was when Tim started. Since about 1970, when payment was first put into place for EMS, so that really hasn't changed. So as communities expect things, or maybe have changing expectations, that changes our cost. Because as we know, the major cost drivers are response times. The shorter that your community wants your response times to be, the more resources you need to have standing by, not on calls, burning money without generating any revenue. ALS, BLS drives cost. If you have all ALS system, it's going to be more expensive than perhaps a BLS system or a tiered system. We're going to talk a little bit about that. And then your deployment model. Are you a fixed deployment model? Do you have the same units on at midnight that you have at noon? Are you working a 24-48 schedule, or what we're seeing now becoming more common is the 48-96-hour schedule, which is kind of weird and perhaps dangerous. But those are some of the major cost drivers for us. And then, of course, for our profession, I mean, And then, of course, you've got all the supplies cost, ambulances, the things that go along with that. So in terms of response volume, here's what we've seen in our system. So you can see how our response volume and transport volume has been steadily progressing. There's that dip in 1920 in the pandemic era, but certainly it's our call volume, and I'm sure yours and your local communities have seen the same sort of thing. And we're seeing it happen across the country. And there's a bunch of news articles and a bunch of, when you go to conferences, you talk to everybody like, oh my God, my volume's up 15, 20%, 10%, whatever it is. And there's really no end in sight. That we've attempted to try and do some analysis to see why that is. It's population growth, but realistically, we've done some per capita analysis amongst the public utility model systems around the country, and the per capita response volume is what's increasing. So it's increasing because the population is growing, but the percentage of EMS responses per capita are also going up. So we have that significant challenge that's occurring. So that becomes a big deal for our communities. And again, we just see this continue to be an issue. What's been fun in our system is that even though our response volume is increasing, our transport volume as a percentage of the response volume has been going down. And part of the reason for that is ET3 and some of the other programs that we're doing to actually prevent transports, but we're getting paid for them. And we'll get more into the ET3 discussion in the second session. So economic challenge. So that's also part of this catalyst for change, right? And in the description, we talk about things that we, the profession, are considering and or doing now. 5 years ago would have been considered heresy, but it's the reality today. And just like drone delivery is becoming popular, the reason that drone delivery is becoming popular is because having drivers deliver stuff is expensive. And Amazon and Walmart and these other places are trying to figure out cheaper ways to get things delivered to your home rather than having to hire people. So part of our economic challenge, as we talked about, is how EMS is funded is either fee for service or tax subsidy. Now you can throw in grants, you can throw in fundraisers, chicken dinners, that kind of thing. That tends to be relatively low level funding. But when you get right down to it, there's really two choices to fund your EMS system: either fund it with taxes or some type of sales tax revenue, whatever the case might be, or the fees that you generate from ambulance transport. And obviously, when your cost is higher than your fees that you can collect per call, somebody has to make up that difference. So it's this sort of hybrid how you look. So here we're going through a little bit of a transition for the MedStar system. When the system was started in 1986, it was heavily subsidized, and it was subsidized all the way through 2009. In 2010, we were able to do some things and improve some efficiencies and improve some economics and do mobile integrated healthcare, et cetera. And we eliminated the subsidy. We went back to the cities and said, hey, that $1.5–2 million that you're spending per year on us, we don't really need it. We're just putting it in the bank. And you can keep it, hire more cops, firefighters, mow the grass in the parks, whatever, but we don't need it. So it doesn't make any sense for us to keep collecting that. And that was fine. And we were putting money in the bank every month, and everybody was fat and happy until COVID. And now for the last 2 years, we've been deficit spending, dipping into reserves. Thank goodness we had a good rainy day fund. And now we've gone back to our member jurisdictions and said, hey, if you want the same level of service that you've been getting, we can't do that on just user fees. So you're going to have to invest some money. We'll talk more about that in just a second. So we are living that real time right here in Fort Worth, Texas, and many of you are perhaps in the areas that you are. We just talked about that. I apologize. So system redesign. So many systems, so many communities are reevaluating how they're delivering service. So patient navigation versus just transport. Can you get paid to treat and refer, to transport to alternate destinations? Do dispatch triage where you don't send anybody? And if you don't send anybody, how are you getting reimbursed for that if the payers might not necessarily be on board yet with paying for dispatch triage? Making sure that you're doing some evaluation. Do you really need a paramedic on every truck? Can you have BLS units? Can you have staffing that includes a medical first responder or a certified first responder and an EMT? Some states are still allowing that, even post-pandemic. And, honestly, there's not been a whole lot of bad clinical outcomes when those types of crew configurations are doing that. Or do you want to use PAs or nurse practitioners? Behavioral health specialists. Colorado is in many respects taking the lead in a lot of this, where you've got these crisis intervention teams California's doing it, Texas is doing it, New York's doing it, a lot of places where you've got a behavioral health specialist with a paramedic or a paramedic with a law enforcement official responding to behavioral health calls. And then taking a hard look at response times. Forever we've said, hey, response times are really important. The reality is that response times are probably less important than we think they are clinically, but the reality is they're easy to measure. And forever, they've been the only real performance measure that we've had. But if you get right down to it, response times aren't a performance measure. They are a process measure. Because they have no correlation in the vast majority of our responses to patient's outcome. And then as part of that, how do you triage calls appropriately to know that, hey, this call needs a high priority response. This call can maybe not have that high priority response. So again, heresy. Is it time to sort of ditch the all ALS EMS deployment? There's been a few very high profile studies that have been published and then republished in national media outlets about ALS, advanced life support care, basic life support care, police department care. So when you get the handout, there are actually hot links to all of these studies, so you don't have to take my word for it. These studies and news reports are actually published. But I think we all know that for penetrating trauma, if it's life-threatening, that you need to get that person to the OR, not the ER, the OR, within a certain period of time. And paramedics in general tend to screw around on the scene of these calls until the patient starts to bleed pink, perhaps because they've gotten so much saline and their blood is diluted, or maybe they're doing a blood program that they can replace some whole blood. But again, cops transporting patients to the hospital have a higher survival rate for penetrating trauma. And this was also a study that was done in JAMA, the JAMA network, that looked at private vehicles, personal cars, taxi cabs, Uber, Lyft, whatever, taking patients to the hospital with penetrating trauma, and the outcome from those transport modes are better than transport modes by ambulance and way better than transport modes with an ALS ambulance. This was sort of the bellwether, if you will, of really started people thinking about this whole ALS, BLS thing because of cardiac arrest, right? If you've been in EMS for a little while, you know that essentially our models are built around cardiac arrest. 8-minute response time. By the way, for those of you that don't know, the 8-minute response time came from the Opal study, I think back in 1979, that said if you get a defibrillator to a ventricular fibrillation cardiac arrest victim within 8 minutes, their chances of survival increase 50%. And as you may recall, in 1979, only paramedics could defibrillate. Well, today, in 2023, a Girl Scout can defibrillate. It's really the most definitive care for cardiac arrest victims. So this was a study that was done by Harvard University, published in JAMA, using CMS claims data. And they looked at ALS treatment and transport to a hospital of cardiac arrest victims compared to BLS response treatment and transport to a hospital, and found that the BLS patients had a higher survival rate than the ALS ambulance, significantly, like 13% versus 9%. So this really began a lot of people, especially when it's published in the Washington Post, to say, why are we paying more for ALS when their outcomes are worse? And do we really need ALS units even to respond to cardiac arrest patients? Because according to this study, again, published in JAMA, paramedics are worse than have worse outcomes than BLS folks. How many paramedics? So there have been a number of studies done on paramedic skills retention and paramedic skills utilization. And those studies have found that the more paramedics that you have in a system, the worse the patient outcomes. And as a former paramedic, current EMT, I can tell you that my experience has been that's true. When I was working full-time as a paramedic and seeing 7 patients a day, I was a pretty decent paramedic. But once I got into management and saw a patient, maybe 7 patients a month, I wasn't as good. So if you've got 4 paramedics on the scene of a call treating 1 patient, you're going to have skills dilution. If you're trying to maintain a paramedic at every station and those stations are responding to 1 or 2 calls a day, they're not going to use their skills, as opposed to a paramedic who is going from call to call to call. Some of you may know New Jersey has a very unique EMS system design requirement by the state, and that is paramedics must be employed by hospitals They can't be employed by agencies, and they must be in fly cars. They can't be on an ambulance. So for years, people said, oh, it's so backwards. That's ridiculous. But, now that we get more evidence and more studies and more research, holy crap, they may be onto something. Because those paramedics, when they're not on a call, they're working in the ER, because if the hospitals have to employ them, they're going to use them when they're not on a call. And they're only going on high acuity calls. So they get to use their skills a lot, because if they're responding to a call and the BLS ambulance arrives on scene and it's not an ALS call, they cancel the paramedic unit. Clinically, that makes a ton of sense. Economically, it's a train wreck, but clinically, it's actually not a bad model. This was a great study that really looked at how many paramedics do you have in a system, and this was an EMS based group that looked at this and basically came to the same conclusion: more paramedics you have, the worse the patient outcomes. And then, of course, that medical journal USA Today, Bob Davis had this down pat when he published a series of articles in 2006 called 4 Minutes to Live or Die in the United States. And he found, reviewing a ton of clinical research, that the more paramedics you have, the worse the patient outcomes. And this was front page in USA Today back in 2006. This was a great study by Dr. Peirce, who's the medical director and the public health director in Houston. And he made the decision several years ago to stop putting paramedics on ambulances, put them all in fly cars, and have every ambulance in the city of Houston run by Houston Fire Department at the BLS level. So today in Houston, every ambulance is BLS, and they have a handful of paramedics in squads that respond to the high acuity calls. And in his review, published in the journal Resuscitation, dramatic increase in cardiac arrest survival rates when he went to that model, because the paramedics were really good at managing cardiac arrest, because they were highly utilized paramedics, because they weren't tied up on the ankle sprain and the behavioral health patient, et cetera, et cetera. So our system had been all ALS for 35 years. Paramedic in every truck, paramedic and EMT. Thank God we weren't dual paramedic, that's even worse. But paramedic, EMT in every truck. But because of COVID, because of staffing shortages, because of economic challenges, in 2009, we wanted to change the model and say, we want to go to tiered deployment, because, 30% of our calls get ALS care, maybe 40%. Trivia question I'll bring up in a minute. But we knew it was very political, right? Because when you've been all ALS forever, changing to something different, especially BLS, it is perceived by some uninformed EMS, by some uninformed community members, as a degradation in care. And you have to show them it's not a degradation in care. It benefits the patient, it benefits the system, it benefits everything. So we put this group together, made up of fire chiefs and first responder organizations and clinicians and the medical director and a couple of hospital representatives. And we, the Office of Medical Director, really looked at 400,000 of our responses over 3 years and put them into buckets. How many of the calls by response determinant, by emergency medical dispatch response determinant, got ALS care, critical ALS care, had a hot transport to the hospital, had unstable vital signs, et cetera, and put those into buckets so that we can identify which emergency medical dispatch determinants are safe to send to BLS unit. Now, through that process, we found out a couple of interesting things. 40% of our 911 response volume resulted in ALS care. Over 70% of the ALS care that was provided was monitor and IV. Okay, well, I would argue that's not ALS care. That's ALS monitoring, but it's not ALS intervention. About 20% of the 911 volume, did the patient receive some type of drug other than oxygen? And interestingly, more than half of the time a drug was administered. Does anybody want to guess what drug was administered? Zofran, probably because of the ambulance ride. So we made Zofran a BLS skill, PO Zofran, and now we're using the alcohol pads, because that has been proven by research to be more effective than Zofran. That's a BLS skill. Anyway, so with this analysis, we were able to say, okay, these are the call determinants, the EMD determinants that are safe to send to BLS unit. So we did, and we started staffing BLS units and putting them out into the field. And these were the determinants that they were eligible to respond to. And they responded to a ton of them. No bad patient outcomes. And you'll notice in these columns, the cells that are highlighted in red, they also had a very low transport percentage. We're going to come back to that in a minute. Now, going to a tiered deployment did two very dramatic things for us. One, it did this. This was our August 2021 New Hire Academy. Historically, and ever since I've been here 15 years. Historically, when we would do a New Hire Academy every quarter, we would have about 8 people. And the reason for that is because we could hire 4 paramedics and we hired 4 EMTs, because why hire more EMTs than you have paramedics when you have to have a paramedic and an EMT on every truck? But when we said, okay, we're going to start putting BLS trucks out in the street, this was the New Hire Academy, 31 people in this New Hire Academy, and 30 of them were EMTs. And they were chosen from a field of over 100 applicants. So these were really, really good EMTs. And they were interviewed by field staff. They were selected by the field staff. So they get to choose who they're going to work with. And I can tell you, we're doing a New Hire Academy this quarter. And yesterday I did my presentation for the New Hire Academy, 29 people in the New Hire Academy, 25 of them are EMTs. Now, the impact that has on the system is this. So look at our average ambulance unit hours staffed per day. So you'll notice in 2019-20, we reduced unit hours because the call volume was down, but we've been pretty consistently that 744, 756 unit hours for the last couple of years. And the system runs really hot. We run a unit hour utilization on a response basis of 50.55, 0.6. So it's a pretty hot system. So then people get burnt out, you have high turnover. But today we're averaging about 812 unit hours per day. And that's because we're putting out more BLS units than we are ALS units. We've even cut back on the number of people who are eligible to go to paramedic school. We pay for tuition reimbursement. We give people a special schedule if they're going to go to paramedic school. And we've cut back on that, saying, we don't really need as many paramedics. So nope, we're not going to, you can go on your own if you want, but we're not going to give you the special schedule, the paramedic schedule. We're not going to pay for your school, because if you want to come back as paramedic, that's great. If we have an opening, we'll let you know. So it's been an interesting dichotomy, if you will. Here's the other thing it's done. It's reduced our cost per unit hour. That was one of the goals and one of the metrics. More unit hours, and we want to reduce our cost per unit hour because, again, we can't afford to keep doing what we're doing because our reimbursements are going down, our costs are going up. So we actually have seen a reduction in our cost per transport, cost per response, and cost per unit hour to try and help make the most effective use of our financial resources. Now, for those of you in the room and those of you online, if I were to put out there, what's the best EMS system in the country besides yours or mine? What's the best EMS system in the country? Right off the top of your head, who would you say? I'm thinking most people are saying Seattle, right? Because Seattle, and they measure EMS system performance based on cardiac arrest statistics, right? So Seattle, King County, has the best cardiac arrest survival rate in the country. Everybody knows that. It might have something to do with their EMS system. It might have something to do with, like, everybody in the community is required to have CPR certification. Can't graduate high school without a CPR card. I think last I heard you can't get a driver's license without showing your CPR card. It's the most dangerous community to pass out, but it's the safest community to have a cardiac arrest in the out-of-hospital setting. But yeah, King County Medic 1, Seattle. Let's look at their system for a second, for those of you that aren't familiar with their system. So in King County, they have 26 paramedic units on duty for a population of 2.1 million people. I can tell you, we have 26 paramedic units on duty today for a population of 1 million. We're trying to get to this ratio, but so that seems like a pretty low percentage. Let's do some math here for a second. So this is King County, and now their population is 2.1 million, but that's resident population. For anyone who's been there, if you go there on a weekday, there are probably another 250,000 people in there for people that commute in for work and all that sort of stuff. So that means that for 2.1 million residents and 2,700 square miles, their paramedic population ratio is 1 paramedic for every 8,600 people. Think about that in your local community if you have paramedic units, all that sort of stuff. Their paramedic unit, paramedic ambulance, ALS ambulance to population ratio is 1 paramedic ambulance for every 82,000 people. Now, I know for a fact that there are people in that audience that have close to that population in their community, and they've got 4 paramedic units on duty. Why? Why? Because the best EMS system in the country doesn't do that. Why are you doing it? Don't you want to be like them? Now, that what's interesting here is that you've also got 1 paramedic for every 90 square miles. Think about that in your communities. Now, the reality is that the Medic 1 units only respond to echo calls. So they are going to the high acuity calls. I would argue that that makes them really, really phenomenal cardiac arrest clinicians, or respiratory arrest clinicians, or shooting in the chest clinicians. Those paramedics are doing critical life-saving interventions on virtually every call they go on. And that's probably a good thing. Makes them really good paramedics. Every other call that's not an echo level call in their system is handled by a contract BLS ambulance provider. Interesting. But they're the best EMS system in the country, according to the data. Now, what are some other systems that are using this tiered response model? Washington, D.C. Now, there was a time, a couple of years ago, maybe up until a couple of years ago, when anyone in EMS mentioned Washington, D.C.'s EMS system, it was the laughingstock of the EMS profession. Horrible system, terrible PR. Things failed left and right. You know, it was a big expose that was done by the local media in DC about how bad the EMS system was, and primarily because they had a reporter who died because he had a head injury, and the the ambulance crew thought he was drunk and told the ER staff he was drunk, and the ER staff believed the ambulance crew, and they put him in the waiting room. And 4 hours later, when they went to go get him to bring him in for an assessment, he'd been dead for 3 hours in the waiting room. But today, DC has one of the best EMS systems in the country. Very high performing, out of the media now, unless it's good stuff. And what the chief there did, the new chief, who came from King County, said, listen, we're going to use the fire department units to only respond to high acuity calls. And we're going to contract with a private provider to do all the bullshit calls. And we're going to do good dispatch triage. We're going to do a nurse triage program, so we're not even going to the lower acuity calls. And that transformed their system and kept them out of the national media. Boston EMS has been doing tiered response for a long time. The interesting thing about Boston EMS is it's a division of the health department in Boston, and they get the science, they get the research, they get the medicine. And the majority of ambulances in Boston EMS are BLS, not ALS. Milwaukee runs a similar system, especially the county, to what King County and DC is doing now, where the fire department ALS units only respond to the high acuity calls, and contract BLS units handle the other calls. The majority of the call volume is handled by BLS contract units in Milwaukee County. FDNY has done this forever. I did my paramedic internship with FDNY. It was actually the Health and Hospitals Corporation back in the day. But the majority of those units are BLS, and they got very few ALS units in their system. And now we're happy to say that MedStar is the same way. So we are a tiered deployment system, so we're happy with that process. Okay, let's talk about response times and hot responses. So this is part of that heresy, right? And changing a dynamic that is redesigning EMS systems, right? There was a day when I first started in EMS, every call was hot, every transport was hot, got to be available for the next call. But really, is that true? So there has been a plethora of research done on response times and their correlation with patient outcomes. And shocker, spoiler alert, zero. No correlate. Well, let me say that back. Very little correlate, because I hate always and never. Very little correlation between response times and outcomes, and no correlation between response time and outcomes if you are not in cardiac arrest. And based on the research, If you're in cardiac arrest, any response time greater than 5 minutes isn't going to make a difference in your outcome, because somebody needs to put hands on the chest within 5 minutes. And I can tell you that most EMS systems that I know of anyway cannot get to the patient side and begin chest compressions in 5 minutes. If we were really serious about response times and cardiac arrest, we would not have we wouldn't have fire trucks and fire stations. We would have Honda Priuses, Toyota Priuses, cheap vehicles parked on street corners with a defibrillator and a CPR trained technician just waiting for a cardiac arrest call, because they might get there in 5 minutes or less, but you need a lot of them, but they're cheap. If you're using a cheap vehicle and a cheap person, and you're just paying a minimum wage because they're just certified in CPR and have an AED, that would make a difference in patient outcomes for cardiac arrest. But here are the many studies that have been published. And again, don't take my word for it. Hot links are here. Go look up these studies yourself. But basically for trauma, medical, and cardiac arrest, and these are all different: urban, suburban, rural, you name it. Here was the one that says, if the response time is lower than 5 minutes, it makes a difference in the patient's outcome. If it's greater than 5 minutes, doesn't matter. 6 minutes, 20 minutes, it's not going to matter in the patient's outcome. So again, a ton of these studies. So I know that in our hearts, everybody in that room, everybody online, we know this. We just don't want to admit it, because that's why we're employed. That's why we have all these paramedics. That's why we have all these EMTs, because we got to get there fast. But really, there is no correlation. That also results in a lot of red light and siren responses, which then results in a lot of crashes. Some of the crashes we know about because an ambulance crashed or a fire truck crashed. However, there are 4 times as many crashes that we don't know about. So the studies have shown, and surveys of EMS practitioners have found, that for every 1 emergency medical vehicle crash, there are 4 wake effect crashes. Now, for those of you who might not be familiar with that term, a wake effect crash is a crash that occurs as people are trying to move out of your way when you're driving hot, or trying to merge back in traffic after you've gone past. It's just like a boat. Boat going down a lake, going down a river, creates a wake. We do the same thing when we're responding hot. I would argue that we all sort of take an oath when we become EMTs and paramedics, and that oath is to do no further harm. If we're creating further harm responding to a call, then that mode of travel is going to yield inpatient outcome. We're negligent, and we're not being consistent with our oath. So several of us feel very strongly about this issue and corralled these national associations. And you can see they run the gamut from physicians, fire groups, EMS groups. I will tell you that normally this group of international and national associations cannot agree on the color of the sky. But thankfully, they all agreed that we as a profession need to reduce the calls that we respond to hot. Dr. Kupis, NAEMT's medical director, the president-elect for the National Association of EMS Physicians, and I were the primary authors on this position statement. And Doug did a phenomenal literature review for NHTSA in 2016, was published in 2017, that had hundreds of studies that he looked at and did a meta-analysis and really made the strong case. The safest thing that we can do for the public, the safest thing that we can do for our practitioners, is to remove the red lights and sirens from the ambulances, because they cause more harm than they improve patient outcomes. Again, because response times have no difference. So if response times don't matter, why are we trying to get there a minute 31 on average, faster to that call when it really isn't going to matter? Now, this position statement, by the way, we did this position statement in 90 days. And it was pushed hard because we didn't want this to languish. We didn't want it to just sort of sit on the shelf. But we also delved into some other parts of EMS delivery and system design. We said, response times need to be de-emphasized. Doesn't matter. Process measure, not an outcome measure. Doesn't matter. As a result, reduce lights and siren. And these are some of the positions. And all these associations agreed. We all signed off on it and said that this is what we believe. EMD should be utilized so people can do good call triage. Responses should drop. Our goal was we should get hot responses down to 30% of the total 911 volume. Transport should be less than 5% of the transports to the hospital. But more importantly, this was the money statement, or the gold ring of this statement. Governmental leaders should realize that hot responses and response times increase risk and should not be a measure of performance of the system. You should be measuring clinical compliance with clinical bundles. You should be measuring cardiac arrest outcomes, which, by the way, if you're not going to get there in 5 minutes, doesn't matter when you get there. You should be looking at patient satisfaction scores, retention, turnover, vehicle crashes. Those are the performance metrics that we should be using, not response time. It's the least important measure that we have. We at MedStar believed so strongly in this back in 2011. Dr. Jeff Beeson was our medical director at the time. I was the operations director, and we put out a directive that said, listen, if you're transporting someone with CPR in progress, you are required to not use lights and siren. Because Jeff looked at all the data. We looked at all the time data. The average time saved on a hot transport in our system was 22 seconds. You can't do good CPR in the back of the truck when you're sloshing around. You can't do good patient care when you're sloshing around. It's dangerous for the crew. It's dangerous for the motoring public. Doesn't save a ton of time, and that time really doesn't matter. So today in this system, if you're transporting someone with CPR in progress, which is rare, by the way, it's a cold transport. No reason to go hot. Now, one of the insights I want to share with you is that when we were rolling this out, we did some town halls. This was a big culture shift for us, and it was a directive. You had no choice. If you're doing CPR, it's a cold transport. If you transport hot CPR in progress, you're going to meet with the medical director, and you're going to get some clinical review. And I'll never forget it. She's still here. One of our most senior paramedics, Shannon Rucker, was in the room on the first town hall. And some of the EMTs and paramedics were moaning and groaning. Well, it's good. We would like going lights and siren, and the patient expects it. And Shannon said, y'all, here's the reality. If we're doing CPR in the back of the ambulance, the reality is that we are relocating a corpse. Because if we haven't gotten them back in the living room, they are not going to get them back in the ER. And we're probably only transporting because of some scene issue, or because the patient coded in aisle 6 at Walmart, and it's bad juju to leave them there. And everybody agreed. So that should be the policy in your communities and in your agencies. Just doesn't make a lot of sense. Now, some fire departments, who, as some of you may know, are known for innovation, have done some pretty dramatic system design changes and got a lot of kudos. So right down the road from, I think, where you guys are, Colorado Springs started doing this a couple of years ago when they, sent lower acuity calls, a community paramedic, and maybe an ambulance isn't coming. We're going to figure out some way to get you to the hospital. The CP decides, is an ambulance warranted? Pretty robust system. Dr. Bronsky and his team did a really good job developing this process. And just this past March, they got a national award for innovation for this model from the fire service. So if you're hesitant about taking the step into this right thing to do for your community, for your agency, for your patients, just know that the Congressional Fire Services Institute thinks that tiered deployment, modified response times based on acuity of calls, is a national best practice worthy of an award. So that's sort of their official position. This just came out this week. So Aurora Fire, I said, hey, we're going to change things around. We're going to respond cold to a lot of calls. And you know what? We're not going to respond to some calls. The 911 system has been using nurse triage for a little while. They're enhancing that, but basically they're saying, listen, we're not going to go hot to these calls. We're going to wait. to go on some of these calls. So it's nice to see these agencies that some might say are normally steeped in tradition really taking a harder look at this. And, I love the quote from the gentleman here. We're following a baseline of the national best practice and what the majority of systems do. But if we need to make change for our area that's unique, we'll do that. But notice he said right here, having right response will allow the department to reduce response times for life-threatening incidents, keep staff in the community safer, and ensure 911 calls get no more or no less than the help they need. Interesting. Probably ground zero for taking a very bold approach to response times, hot responses, that system redesign, if you will, is MEDIC, the Mecklenburg EMS agency in Charlotte, North Carolina. They are a governmental agency. They're part of AIM High. They're a high performance EMS system. They're owned by the county, and they're all county employees. And they've taken a pretty unique approach. So, and you may have noticed, by the way, some of the research that we showed earlier came from Mecklenburg, Charlotte, because they've done a lot of research into this. And they changed their response time guidelines. 11:15 or 10:59 for high acuity calls, 12:59 for urgent calls. But look at these. So for a Bravo and Alpha level call, and for Omega level calls, 60 and 90-minute response time expectation. So you can imagine someone in your community calling 911 and your dispatcher telling them, hey, Kim, thanks for calling. Here's the deal. We appreciate you. We really like you. You've got a low acuity medical complaint. We're going to send you an ambulance, but we're going to keep other ambulances available for, more serious calls. We'll have an ambulance at your house within the hour or within the hour and a half. But they tell the caller that so that they can set the expectation for that 911 caller about when the ambulance is going to arrive at that call. Yesterday, this was published in Knox News, which is part of Gannett, and Knox County, Tennessee, going through a tough transition, right? So they had an unsubsidized system with a private contractor, GMR, for years. GMR said, we can't do this for free anymore. Costs skyrocketed, reimbursement sucks. Your expectations are high in terms of response times. So if you want the current response times that you've been getting, we need a $2 to $3 million subsidy. Well, the county said, we don't believe you. So we're going to get a consultant to come in and give us a third-party opinion. So Todd Sheridan and Fitch and Associates went in, did a big study and said, no, they're right. Here's the deal. If you want this level of service, you have to pay for it. It's $2 million a year, $3 million a year, whatever the case is going to be. So now the community has a decision. But what was interesting in this news report, the reporter called me and I did an interview with him, but I also told him about Charlotte. So the reporter called Charlotte and talked to JP Peterson, the executive director at MEDIC, and they published this in the local newspaper. Said, you know what? For low acuity calls, they have up to an hour to arrive. It's actually up to 90 minutes now, went into effect October 1st. But here's how it was depicted in the article. Charlotte Metro wait times have gotten longer, and leaders brag about it. And the reason they're bragging about it is nobody's died, no bad outcomes, no complaints about response time. And I asked JP, how is that possible? You've done 30,000 of these calls where you had a response time of an hour-ish, maybe longer, and you've got no response time complaints? He said, no, we told the caller we're going to be there in the hour. They don't call and complain unless it's an hour and a half. They call and complain. So we give them the expectation. And like today, if it's 90 minutes, we tell them we'll be there in an hour and a half. Okay. So everybody just waits, and then because they expect the ambulance within an hour and a half. What that's done for MEDIC is it's allowed them to right-size resources, not respond to the low acuity calls until they're at a system level that they can respond to, so that they're keeping ambulances available for the high acuity calls. And they've reduced their subsidy. For the last 2 years, when they went to 60 minutes, now going to 90 minutes, they've reduced their subsidy substantially from the county, and they are not stacking bodies like cordwood at the county courthouse. Nobody has died, no bad outcomes, and again, no complaints. So we did it, right? So, but not to the same extent that he did. We reprioritized our system, We found in that analysis that 2.05% of our 911 response volume gets a potentially life-saving intervention. So we said, okay, what about the other 90% of the calls that don't have that? We need to reprioritize. So we were able to reduce our hot responses from 74% of our responses to 31% of our responses. And we did that March 1st. Nobody has died. We're not stacking bodies like cordwood at City Hall, just like Charlotte. We've reduced the fire department's first response volume dramatically because in our system, Fort Worth Fire does not respond generally to calls unless we're going hot. And they said from the beginning when we went through this process, listen, the fire chief said, our philosophy is if you're not going hot, we don't need to go. Okay, great. Cut the call volume 40%, which made them more available for the cardiac arrest and the trouble breathings and all sorts of stuff. As we were going through that process, one of the things that we evaluated was customer expectation, public expectation. And we've been blessed for the last, since 2013, we've used EMS survey team to do patient experience scores. One of the questions on the survey is the timeliness of the ambulance's arrival. It's a Likert scale, 1 to 5, 5 being most satisfied. How satisfied were you with the timeliness of the ambulance arrival? We took the 1,400 responses to that survey where it was an ambulance-only response, no first responders, so that there was no, misconception that the ambulance arrived in 10 minutes because the fire truck got there. And we were getting the patient experience scores for that question, timeliness of the ambulance arrival, as 5, even up to a 60-minute response time. So this concept of people saying, well, the public expects a fast response, they expect the response that you tell them they're going to get. That's how it's always been. If you tell them I'm going to be there in 8 minutes, okay, that's what they expect. If you tell them, hey, with your ingrown toenail, we'll be there today. Okay, just come out by today. Just, we have to do some right sizing of expectations in the community just to be able to survive with the workforce shortage, the economic challenges that we're having. Again, 3 years ago, this conversation was heresy. Today, it's necessity because we just can't survive. NAEMT did a big national survey about what systems have done to redesign their system because of costs, shortages, pandemic issues, etc. 420, I think, 10 responses to this survey, the majority of them fire departments. And when you look at the responses, what are the biggest changes to delivery system? And 114 out of the 400 and whatever agencies that responded said they've lengthened the response times. We don't hear a sudden increase in death from ingrown toenails in the community. A number of 85 of them have said they're now responding with an alternate response to low acuity calls. That might be a first response unit only. That might be a squad. Or like in our system, we put out some fly cars and even EMT fly cars and said, okay, for an Omega Alpha level call that has a low transport percentage, why are we sending an ambulance? If we know that the 31 Alpha 3 unconscious person down in a park on a bench, 14% of the time results in a transport, why in God's green earth are we sending an ambulance when they're only going to transport 14% of the time? Keep that ambulance for the 10 Echo 6, which has 100% transport rate. And that just makes more sense, and it makes more clinical sense, makes more operational sense, and certainly makes more economic sense. The Academy for International Mobile Healthcare Integration, AIM-HI, is a group of public utility model systems and some other high-performance EMS systems. We just finished the benchmark report for 2022. And notice how many of these systems, regarded as some of the best systems in the country, high performance, low cost, low subsidy, like Mecklenburg, like MedStar, like Reno, like Pinellas County, change response time goals, transition from contractor, brought it in-house, increase the use of nurse health lines. These are the systems that are part of that benchmark study. And look at how many of them have transitioned from an all ALS to tier deployment. 36% of them have transitioned. 64% don't use medical first responders on every call. They save them for the high acuity calls. And look at some of these response time standards in those communities. So Tulsa, Oklahoma City, Their high acuity response time standard, 11 minutes, 90% reliability. Low acuity, 25 minutes. There's Medic, Charlotte, 60 minutes. Medic in Solano, California, 25 minutes. Look at the ones here at Northwell, Remsa, and Richmond, 90 minutes. I'm sorry, 30 minutes and 20 minutes respectively. But look at Pinellas County, low acuity response in St. Pete, Clearwater Beach, which is Pinellas County, God's waiting room, arguably. There's no standard for low acuity 911 call. Get there when you get there. That's sort of where we need to probably go as a profession, because we just can't keep doing what we're doing. We talked a little bit about this already. Do you just send a QRV to those calls? Because you really don't need to have a full ambulance to those calls that have a low percent transport. I'm sorry, it was a 32 Bravo 3, 19% transport rate. Motor vehicle crash, that codes as a 29 Bravo 3. If you got a 16%, 17% transport rate, why are we going? Fire department's going to go. We don't go. Hey, when you guys get there, if you need us, call us. That's what Austin does. Austin Travis County EMS doesn't go on on any 29 Alphas, 29 Bravos. They say, hey, if the patient wants to go to the hospital, call us. We'll come out. It's just something we need to do. Use of AI. So this is a big discussion with NAEMT and now across the country. St. Louis County was one of the first counties to really start using AI for automatic call distribution in their 911 center. If you think we're having staffing shortages, PSAPs are worse. Jerry Overton shared some data at Navigator last year. 84% of the PSAPs across the country report below level staffing. And quite frankly, I think that 84% was that they were on an 84% was at critical staffing levels because they just couldn't hire people. Becomes a big problem. So how can we figure out how to use AI to alleviate the staffing shortages in the communication centers? In fact, MPDS, Medical Priority, is doing a study right now. And I think we're participating in that study, looking at the caller's voice stress level to correlate to the severity of the patient on scene. And the reason they're doing that study is that they can use that to use AI to determine the priority of a response, running in the background. So based on the headset, the call taker's taking the information, the computer system says, hey, this person's VSA is super high. This might be pretty legit. It's a pretty serious call. As one of the ways to help augment, do you need to go hot? Do you not need to go hot? Do you need to go within 5 minutes? Do you need to get there today? Using AI to do a lot of that. It's a good idea. All right, so as we wrap up, take-home messages before we do Q&A. These are probably the most challenging times we've ever had in the EMS profession. We need to do things differently. It doesn't matter your service model. Fire departments, I was just reading another article about fire department that said, oh, yeah, you know what? We're sort of underwater. We're going to need an extra $1 million to do what we're doing. At the same time that you've got private providers saying, we need $1 million subsidy. It doesn't matter. And when we're here for the second session, you'll see how some of that recruiting is going, even for fire systems. Use this opportunity, use the crisis, leverage the crisis. Jonathan Washko uses the statement all the time for Northwell. I love it. Let no crisis go unleveraged, because we can get permission to do things today that people wouldn't even talk to us about 3 years ago. Use that. It includes the economic model. And bottom line, response time is not a quality measure. It's a process measure. You should not be measuring system performance based on response times. It has no correlation. You can have an ambulance at somebody's address in 7 minutes with 90% reliability, but if they give shit clinical care, you're gonna have bad outcomes. You have a paramedic ambulance or an ambulance that responds in 20 minutes, and they are really good clinicians, they're gonna have good outcomes of their patients. Response time is not a determiner of patient outcomes, or I'm sorry, of system performance. Kim, I'm gonna let you, I haven't looked to see if we have any questions or anything in the chat or the Q&A feature, but I'll open it up for anybody that has some. And while we're waiting for some of those questions, if you want to hold your phone up to the screen, either online or in the room, I'm going to make this easy for Kim. That QR code will automatically generate an email to me asking for the copy of this presentation. I will reply to the email and attach a PDF of the presentation. So I'll make it really easy for Kim so he doesn't have to go through that whole process.
Thank you.
Questions?
I've been monitoring chat and hands up, and there haven't been any so far. Is there anyone online or here in the room that has a question for Matt Zavetsky? I do. Tim.
Matt, when you're looking at some of these response criteria, ALS versus BLS, have there been any studies done in the rural environment? And what's that looking like?
There have been studies done in the rural environment. I would admit that rural community is going to be a little bit different because two reasons. One, transport times. Two, people in the rural communities tend to be a little bit more robust, a little bit more self-sufficient. And they're not going to call 911 unless they are really having an issue. So there may be some consideration here for rural communities and having, all ALS or whatever, but I've worked with a lot of rural systems that they can't get paramedics either. So the hospital, typically the critical access hospital, employs a paramedic. Paramedic works in the ER to keep their skills up and co-responds with the local ambulance provider, much like the New Jersey model. And I'm going to go to some of these, Tim. If I remember correctly, a couple of these studies were rural communities when it came to response times. So look through it when you get it, because they did look at both rural and urban.
So here's a chat, and it's from Sherilyn Whitler, who is truly rural, frontier down in the southeast part of the state. She's interested in the rural environment context also. And I would suggest that in some of our more frontier areas, I'm sure those areas exist in Texas too, an 8-minute response time isn't possible if you've got a rocket up your ass. It's just not going to happen. So,
Isn't that an interesting way of describing it?
yeah, there's just not going to happen.
No, and that's fine. So the community gets what the community is willing to fund. I'll argue that's the issue. Because this, at the end of the day, it's an economic discussion, right? Response time. Because if Frontier County, Colorado, still wanted to have an ambulance in front of an address in 8 minutes, okay, it's going to cost $30 million. We're going to, hire a bunch of people at $180,000 a year, and they're going to be positioned at the entrance of every ranch. So we can, or they say, we can afford $100 a year for EMS. So when you get there, thank you for the effort. Okay.
Matt, we have another question in the room. Janae?
Was the ALS, BLS designator based on their guidelines, or what differentiated between what they define as ALS and what another agency might?
Are you talking about this?
BLS.
It depends on who you're asking. So in our system, we define ALS or BLS by either having a paramedic on an ambulance or not. I think where part of the question might come up from is the cardiac arrest study, where they had an ALS at lower survival rate. That was Medicare claims data based on how the ambulance claim was billed. So was it billed at the ALS level? Was it billed at the BLS level? Because the researcher doesn't know who's on the truck. They know how it was billed because they were using claims data. So arguably, if you didn't have a paramedic on the truck, you didn't bill ALS. You built BLS because you can't bill ALS unless you have a paramedic on the truck. Or whatever the ALS provider is determined by your state. So it could be an EMT advanced, whatever, but still an ALS provider.
And is that your question actually? Because was it response related? So who determines the level of response with this ALS versus BLS? Is it a dispatch determinant or is it a medical protocol determinant? Is that?
Yeah, because if you take ALS off of your rigs and send BLS crews out first, I think what the difference is, we would define BLS as someone who can give Zofran and monitor IDs and start IDs, where in other parts of the country, only paramedics can do IDs and Zofran and stuff like that, which would make a big difference in response.
Did you hear the question, Matt?
I did. So The medical director decides what call is going to get an ALS or a BLS response by determinant. So here's our list of determinants that were eligible based on the review of our data, having a very low incidence of hot transports, very low incidence of medication being administered, et cetera, et cetera. So these were the response determinants that the medical director said was safe to send a BLS unit. The dispatchers assign the BLS unit. So if they triage the call and it comes out as a 23 Bravo 1, they're going to dispatch a BLS unit because it's eligible for BLS. Now, part of the tough discussion in our system was the second most popular drug administered after Zofran was fentanyl for pain. Well, okay, there's varying levels of pain, and there's a reason why CMS took pain management off the patient experience score surveys. Not saying that caused the opioid crisis or anything, but sometimes the patient's got to tough it up a little bit. Ice pack, Tylenol during transport, blah, blah, blah. The use of fentanyl to ease pain is okay. It is not a critical intervention. It's not going to save somebody's life. It's going to make them more comfortable. So there are some cases where you go to a car crash and the person's got a twisted ankle. Yesterday, if it were an ALS unit, they may have given them fentanyl just to take the edge off. Today, it's 2 EMTs on the truck. They splint it, put an ice pack on, and say, hold still so it doesn't hurt. Kind of like we did back in the day, and nobody died.
Matt, does some of the outcomes relate to the quality of the dispatch center? So in some of these bigger cities, they probably have really high tech, a lot of good training for their dispatchers to apply the appropriate determinant code to the call. In a lot of rural areas, they don't even use any sort of medical priority dispatch. I mean, I just found out yesterday, pretty disturbing, like Park County, a county just to the west of our service, they closed their dispatch center down at 10 o'clock at night and transfer it to another county to dispatch at night. How is a lot of this stuff based on the quality of the dispatch, the information coming in before they can get the information or apply the appropriate determinant out? How do we, until we get the AI in the dispatch system, how do we fix that? I mean, that could be a funding priority.
Don't shoot the messenger. The reality is that any PSAP can do EMD. I was at a PSAP in the UP of Michigan 2 years ago. They had a staff of 1.5. When the call taker needed to use the restroom, she took the radio and the portable phone with her. And they did EMD. And they asked the questions. And the reality is when you have a dispatch center like that, you've got time to do EMD. And you just need to make the commitment to train them to do it. Oftentimes it's law enforcement. They're not interested in doing it, blah, blah, blah. APCO is fine. APCO does allow you to do call triage. MPDS for certain allows you to do call triage. And it is not expensive to do. It is not expensive. You can use the cards for crying out loud. It's peanuts. Now they're tablets. And if you're not doing emergency medical dispatch in your community, I'm going to say it, shame on you.
Okay, thank you. I think we're getting to start our next presentation. Is that right?
Yes.
So Matt, thank you very much for joining us in Colorado Springs, all the way from Fort Worth, Texas.
You'll be back at 10:50.
Be back in a little while.
Yep, excellent. Thanks, Matt.
Bye, all.
We'll give it just a second here to do a little transition. Is there any other comments, any thoughts while we're getting Matt?
So I was going to ask Matt if you looked at or they're using AEMTs out there, and if that's included in their tiered response model, but because we're taking that very seriously in Gunnison. And it's kind of a new thing, last couple of years.
So I need, oh, there he is, okay.
So Isabella is connecting to the audio as we speak. Anybody else thinking about a tiered response in the room or online? Changing the response model?
we're looking at it, and then I'm really interested in, there's a lot of talk of regionalization, and I'm curious with nurse triage, which I have a little bit of heartburn about, but I know the research says paramedics can't do phone triage as well as nurses. But arguably, we just need to train paramedics better. But anyway, is that an opportunity for regionalization in Colorado where, like, I know I can't afford to have a nurse in my dispatch center triaging calls. I'm assuming that CJ can't either. Is there an opportunity to regionalize that sort of thing and help get the tiered response?
Indeed, I think that's a great conversation that we need to have even from the 225 Sustainability Task Force in resources in general. Okay, we're going